This lecture is on acute mesenteric ischemia. The learning objectives of this lecture is to define mesenteric ischemia, to understand the anatomy and physiology of mesenteric vascular supply, to outline the causes of acute mesenteric ischemia, to identify the clinical presentation, diagnosis, laboratory and radiologic studies available, and to understand current treatment options. Mesenteric ischemia is caused by a reduction in intestinal blood flow, which most commonly arises from occlusion, vasospasm, and/or hyperperfusion of the mesenteric vasculature. It is important to identify mesenteric ischemia because the clinical consequences can be catastrophic, including sepsis, bowel infarction, and eventual death. Intestinal ischemia can be divided into acute and chronic, based upon the rapidity and degree to which blood flow is compromised. Acute mesenteric ischemia refers to the sudden onset of intestinal hyperperfusion, which can be due to occlusive or non-occlusive obstruction of arterial or venous blood flow. Occlusive arterial obstruction is most commonly due to emboli or thrombosis of mesenteric arteries, while occlusive venous obstruction is most commonly due to thrombosis or segmental strangulation. Non-occlusive arterial hyperperfusion is commonly due to primary splenic vasoconstriction. Chronic mesenteric ischemia, also known as intestinal angina, refers to episodic or constant intestinal hyperperfusion, which usually develops in patients with mesenteric atherosclerotic disease. For the purpose of this lecture, we will only talk about acute mesenteric ischemia. The vascular supply of the intestines consists of the celiac artery, superior mesenteric artery, inferior mesenteric artery, as well as its network of collateral circulation. This extensive collateral circulation exists to protect the intestines from transient periods of inadequate perfusion. However, prolonged reduction in splenic blood flow leads to vasoconstriction in the affected vascular bed, which can eventually reduce collateral blood flow. The likelihood of developing intestinal ischemia depends upon 1. The adequacy of systemic perfusion and collateral circulation, 2. The number and caliber of splenic vessels that are affected, and 3. The duration of ischemic insult. The celiac axis. The celiac artery arises from the anterior aspect of the abdominal aorta and typically branches into the common hepatic, splenic, and left gastric arteries. The common hepatic artery usually gives rise to the gastroduodenal artery, which in turn branches off into the right gastroepiploic artery and the anterior and posterior superior pancreatico-duodenal arteries. The right gastroepiploic artery joins with the left gastroepiploic artery. The right gastric artery branches from the hepatic artery and anastomoses with the left gastric artery along the lesser curvature of the stomach. Because of its highly redundant blood supply, gastric ischemia is rare. The superior mesenteric artery. The SMA usually arises approximately 1 cm below the celiac artery and runs inferiorly towards the cecum, terminating as the ileocolic artery. Along its way, it gives rise to the inferior pancreatico-duodenal artery and several jejunal and ileal branches, as well as the middle colic artery and the right colic artery. As a general rule, the middle colic artery arises from the proximal SMA and supplies the proximal to mid-transverse colon. However, it occasionally provides the predominant blood flow to the splenic flexure. The right colic artery arises either from a common trunk or just below the middle colic artery, and supplies blood to the mid-distal ascending colon. The ileocolic artery supplies the distal ileum, cecum, and proximal ascending colon. The inferior mesenteric artery usually arises approximately 6 to 7 cm below the SMA. The IMA gives rise to the left colic artery, the sigmoid arteries, and the hemorrhoidal arteries. It is responsible for blood supply from the distal transverse colon to the rectum. The splenic collateral circulation imparts redundancy and as a result, provides substantial protection from ischemia or infarction. The major collateral connections are, firstly, the celiac artery and the SMA, which communicate principally through the junction of the superior and inferior pancreatical duodenal arteries. 2. The SMA and IMA, which communicate through several pathways. These include the middle colic and left colic arteries, which anastomose through the marginal artery of Germone, which runs along the mesentery of the splenic fracture of the colon and the arc of Rowland. Thirdly, collaterals between the IMA and systemic circulation, which occurs in the rectum as well as the superior rectal or superior hemorrhoidal vessels, which merge with the middle rectal vessels from the internal iliac arteries. Mesenteric physiology. Changes in the resistance of mesenteric arterioles account for wide fluctuations in splenic blood flow. This can range from 10 to 35% of cardiac output. There are numerous control mechanisms that contribute to the regulation of mesenteric vascular tone and are responsible to varying conditions such as postprandial state or systemic hypertension. Intrinsic autoregulation of blood flow by the splenic vessels is thought to occur in response to acute reductions in perfusion pressure. Neuro and hormonal mechanisms also contribute to the extrinsic control of intestinal blood flow. These include the sympathetic nervous system, the renin-angiotensin axis, and vasopressin. Ischemic injury to the intestine develops when there is insufficient delivery of oxygen and nutrients required for cellular metabolism. The intestine is able to compensate for approximately 75% of acute reduction in mesenteric blood flow for up to 12 hours without substantial injury. Collateral circulation opens almost immediately after occlusion of a major vessel. However, after several hours, progressive vasoconstriction develops in the obstructed bed, increasing its pressure and thereby reducing collateral flow. Vasoconstriction may persist even after blood flow has been restored, leading to continued intestinal ischemia and providing the rationale for therapeutic infusion of papaverine, which is a vasodilator. Ischemic damage is caused by hypoxia and reperfusion injury. Most of the damage is due to reperfusion injury after a brief period of ischemia, while the detrimental effects of hypoxia predominate with longer periods of ischemia. Acute mesenteric ischemia. Acute insufficiency of mesenteric arterial blood flow accounts for 60 to 70% of cases of mesenteric ischemia, and this results in approximately 60% of mortality. The specific risk factors include advanced age, atherosclerosis, low cardiac output states, cardiac arrhythmias, severe cardiac valvular disease, recent myocardial infarction, and intra-abdominal malignancy. The four major causes of acute mesenteric ischemia are superior mesenteric artery embolism, superior mesenteric artery thrombosis, mesenteric venous thrombosis, and non-occlusive ischemia. It is also to note that less frequently, acute mesenteric ischemia can also occur in the setting of underlying vasculitis. Mesenteric arterial embolism. Embolism to the mesenteric arteries is most frequently due to dislodged thrombus from the left atrium, left ventricle, or cardiac valves. The SMA is anatomically most susceptible to embolism due to its large caliper and narrow takeoff angle from the aorta. The IMA is rarely affected due to its smaller caliper. The embolus usually lodges 3 to 10 cm distal to the origin of the SMA, in a tapered segment distal to the takeoff of the middle colic artery. Approximately 15% of emboli lodge in the origin of the SMA. Over 20% of acute mesenteric emboli are multiple. The middle segment of the jejunum is most often involved in the ischemic process, as it is most distant from the collateral circulation of the celiac and inferior mesenteric arteries. Mesenteric arterial thrombosis. Acute thrombosis of the mesenteric circulation usually occurs as a superimposed phenomenon in patients with a history of chronic intestinal ischemia from progressive atherosclerotic stenosis. It can also occur in the setting of abdominal trauma or infection. There is no significant association between inherited coagulation defects and mesenteric arterial thrombosis. Thrombosis of the SMA or celiac axis usually occurs at the origin of the vessel and involves at least two major splenic arteries. Mesenteric venous thrombosis. Risk factors for the development of mesenteric venous thrombosis include hypercoagulable states, portal hypertension, abdominal infections, blunt abdominal trauma, pancreatitis, splenectomy, and malignancy in the portal region. Intestinal ischemia following mesenteric venous thrombosis is due to the resistance in mesenteric venous blood flow, which causes profound bowel wall edema, fluid efflux into the bowel lumen with resulting systemic hypotension and an increase in blood viscosity. As a result, arterial blood flow is diminished, which ultimately leads to submucosal hemorrhage and bowel infarction. Up to 75% of patients with mesenteric venous thrombosis have an inherited thrombotic disorder. This is commonly in the form of factor V latent mutation, which is present in about 20 to 40% of patients. There are also a number of conditions that are associated with acquired forms of hypercoagulability. Most commonly, these are paroxysmal nocturnal hemoglobinuria, myeloproliferative syndromes. Non-occlusive mesenteric ischemia. Non-occlusive mesenteric ischemia, or NOMI, is thought to occur as a result of splenic hypoperfusion and vasoconstriction. Similar to mesenteric arterial thrombosis, non-occlusive mesenteric ischemia tends to develop in patients with significant atherosclerotic and vascular disease. A typical patient is usually elderly with cardiovascular disease who has a life-threatening complication, such as myocardial infarction or congestive heart failure, and is being treated with drugs known to reduce intestinal perfusion, such as diuretics. Other common inciting events include aortic insufficiency, sepsis, cardiac arrhythmias, and administration of medications such as digoxin and alpha-adrenergic agonists. The pathogenesis of NOMI is related to mesenteric vasospasm, which is a hemostatic mechanism that functions to maintain cardiac and cerebral blood flow at the expense of splenic and peripheral circulation. Vasopressin and angiotensin are probably the neurohormonal mediators of this phenomenon. The villus tips are most susceptible to injury because of their relatively high oxygen requirement. The severity and location of the abdominal pain that accompanies NOMI is usually more variable than the classic severe pain of acute occlusive mesenteric ischemia. Thus, a high index of suspicion in elderly patients with risk factors for NOMI is imperative for making a prompt diagnosis. Clinical presentation. Patients with acute mesenteric ischemia have been classically described as having the rapid onset of severe paraumbilical abdominal pain, which is often out of proportion to findings on physical examination. Nausea and vomiting are also common. Sudden pain associated with minimal abdominal signs and forceful bowel evacuation in a patient with risk factors for acute mesenteric ischemia should greatly heighten the suspicion for the diagnosis. Presentation may be more insidious in patients with mesenteric vein thrombosis, in whom symptoms may have been present for weeks to months before diagnosis. About half of patients have nausea and vomiting. Non-specific abdominal pain may be the only feature in patients with a subacute presentation, while those with chronic mesenteric ischemia may present with bleeding from esophageal or gastric varices due to concomitant portal or splenic vein thrombosis. To note, abdominal pain is absent in up to 25% of patients with non-occlusive ischemia. To differentiate the features of pain and presentation between small bowel and colonic ischemia, there are several features. Firstly, severe pain is more likely to be with acute mesenteric ischemia involving the small bowel. In patients with small bowel obstruction leading to ischemia, pain often precedes vomiting. The onset of pain is sudden when ischemia is caused by embolic disease. In contrast, the pain may occur more insidiously in patients with thrombotic causes, vasculitis, or non-occlusive ischemia. Lower abdominal pain associated with hematochezia is more likely with colonic ischemia. Laboratory investigations. Laboratory studies are often non-specific, while abnormal laboratory values may be helpful in bolstering suspicion for acute mesenteric ischemia. Normal laboratory values do not exclude AMI and do not justify delaying angiography when clinical suspicion for mesenteric ischemia exists. Common laboratory findings may include marked leukocytosis with a predominance of immature white blood cells, an elevated hematocrit consistent with hemoconcentration, and metabolic acidosis. A useful clinical guideline is that any patient with acute abdominal pain and metabolic acidosis has intestinal ischemia until proven otherwise. Other laboratory markers include elevated serum lactate, amylase, and phosphate. Radiologic studies. Mesenteric angiography remains the gold standard diagnostic study for acute arterial ischemia. Both anterior-posterior or AP and lateral views are needed for adequate visualization of mesenteric vasculature. The origins of the celiac axis and SMA are visualized only on the lateral view, while the distal celiac axis and remainder of the SMA are assessed best with AP projections. Angiography is relatively less sensitive for superior mesenteric vein thrombosis. In patients with NOMI, arteriography can demonstrate areas of narrowing and irregularity in major branches, decreased or absent flow in smaller vessels, and an absent mucosal blush. Mesenteric venous thrombosis may be diagnosed during the venous phase of the exam by the presence of venous filling defects or absent flow. In addition, resistance to venous flow permits visualization of reflux contrast into the aorta. In severe cases, contrast extravasation into the bowel lumen may be seen, indicating active bleeding. Isolated mesenteric vein thrombosis may be more difficult to diagnose compared with mesenteric vein thrombosis that also involves the portal or splenic veins. Other radiologic modalities include Doppler ultrasound, CT scans, as well as MRA, and the latest generation of CT angiography known as multi-detector row CT. The treatment goals of acute mesenteric ischemia is to restore intestinal blood flow as rapidly as possible. Initial management should include aggressive hemodynamic monitoring and support, correction of metabolic acidosis, initiation of broad-spectrum antibiotics, and placement of an NG tube for gastric decompression. Vasoconstricting agents and digitalis should be avoided if possible, since they can exacerbate mesenteric ischemia. If vasopressors are required, dobutamine and low-dose dopamine are preferred. Systemic anticoagulation should be administered to prevent thrombus formation or propagation, unless patients are actively bleeding. Anticoagulation is typically reinstituted after surgery to prevent new thrombus formation. Surgery should not be delayed in patients suspected of having intestinal infarction or perforation. In other patients in whom the diagnosis is unclear, the early performance of mesenteric angiography is imperative. Hemodynamic stability should be achieved prior to the study, since angiography will demonstrate mesenteric vasoconstriction, even in the absence of mesenteric ischemia. Therapeutic options during angiography include the administration of intra-arterial vasodilators or thrombolytic agents, angioplasty, placement of a vascular stent, and embolectomy, depending upon the cause of ischemia and anatomy of the obstruction. The treatment of mesenteric arterial embolism. The traditional treatment of mesenteric arterial embolism has been early surgical laparotomy with embolectomy. Surgical embolectomy is accomplished by performing an arteriotomy distal to the embolism and then advancing a balloon-tip embolectomy catheter. Palpation for SMA pulses is performed, and the small bowel is carefully examined for areas of persistent ischemia, which are then resected. Intraoperative ultrasound can assist in identifying persistently ischemic segments. Post-operative administration of piperacillin can attenuate associated vasospasm. A second look laparotomy within the next 24 to 48 hours may be necessary to resect additional ischemic or gangrenous bowel. The management for mesenteric venous thrombosis includes heparin anticoagulation and resection of infarcted bowel. Anticoagulation with heparin can be given even in patients who have gastrointestinal bleed, if the bleeding risk is considered to be outweighed by the risk of intestinal infarction. The treatment for non-occlusive mesenteric ischemia usually involves piperacillin infusion through the angiographic catheter and an attempt to reverse the underlying condition leading to splenic vasoconstriction. In patients without peritoneal signs, repeat angiography can be performed in 24 hours to verify resolution of vasoconstriction. Surgical exploration should be limited to patients with peritoneal signs. In summary, acute insufficiency of mesenteric arterial blood flow accounts for 60 to 70% of cases of mesenteric ischemia, and this results in mortality rates exceeding 60%. The diagnosis of acute mesenteric ischemia depends upon a high clinical suspicion, especially in patients with known risk factors. Rapid diagnosis is essential to prevent catastrophic events associated with intestinal infarction. However, early signs and symptoms of mesenteric ischemia are nonspecific, and definitive diagnosis often requires invasive testing, exposing the patient, who typically have several comorbidities to risk. As a result, diagnosis is often delayed. Mesenteric angiography remains the gold standard diagnostic study for acute arterial ischemia. The goal of treatment of patients with acute mesenteric ischemia is to restore intestinal blood flow as rapidly as possible after initial management that includes aggressive hemodynamic monitoring and support, correction of metabolic acidosis, initiation of broad-spectrum antibiotics, and placement of an NG tube for gastric decompression. These are the key references used for this lecture. Thank you.